right, everyone, welcome back. We are going to move on to step two, self-empowerment for clients. And in these, we're going to talk about psychoeducation, cognitive retraining, and meaning making as part of the trauma narrative process. The first thing I want to talk about is psychoeducation, and I've probably written this notes about psychoeducation in some of your reading note cards or talking about other aspects of the process. This is going to sound counterintuitive to what I would consider a very complex topic of trauma treatment. However, one of the most important things you can do as a clinician is proper psychoeducation with your clients. And that means helping them understand what's happening in their bodies and their brain as part of a trauma process. And that doesn't mean that you're going to explain it the same way to every single one of your clients. You'll need to think about things like developmental level. You'll need to think about things such as, what type of trauma they occurred and maybe what symptoms you see them exhibiting the most. However, it can be incredibly validating and normalizing for a client to learn about the trauma process. Not only does it help normalize it, but it also turns them into an advocate for mental health because they will go out and tell other people about this as well. And so not it helps the client, but it helps others because they are able to learn about the brain, and it can help the family members, it can help employers or coworkers understand what the person is going through. So some of my thoughts on psychoeducation are you can create your own handouts or download them from trusted sites, which means you want to compare that information to information you learned in this class or from other readings to make sure it is legitimate. You can also, I think I don't have videos on here, but I kind of think of those the same. Like anytime I put a video from YouTube or another source, I watch it fully. I make sure it's not shady or, information that someone kind of made up based on extrapolations from research studies. So videos and handouts, make sure that you vet them very well before you share them with your clients, but they can be helpful. Books, don't recommend a book you haven't read. That can get you in a lot of trouble. So read books beforehand. Things like The Body Keep the Score, I think, can be a good client read if the client is able to process the material. If that feels like too heavy of a lift, something like Oprah Winfrey and Bruce Perry's book, What Happened to You, might be a good recommendation. It's just a starting book on trauma. But also get recommendations from other clinicians, keep a list, have it as your, to read list. And then also once you've read it, if you think that it's a good fit, move it over to your recommendations list for clients. A lot of clients will want to read books to learn more about their own condition and what's happening with them. Psychoeducation is a huge form of normalization for clients. It talks, you can talk about the prevalence, how often things like this happen, myths associated with trauma, things like, oh, that just happens to veterans, and oh, that just happens when people are already, mentally unwell, things that we know are not true. But may still be prevalent in just sort of, lay people outside of the mental health professions' thoughts about trauma. Things like typical responses to trauma, and then atypical, and then the biology of trauma, and how that unprocessed trauma can affect a person's life, not just right after the trauma, but for the rest of their life if it is not processed. If the body does not find a way to discharge the trauma and move on. My only note of caution is when you use psychoeducation, make sure you are using it in a way that the client understands is to help them, not to set yourself up as the expert or know-it-all. You don't want to come off as patronizing, minimizing, or exclusionary, like I'm such a smart academic and I know all these things. Instead, offer the psychoeducation as a way for them to fully understand their body and what they're going through. And it's completely normal to not know these things beforehand unless you're doing this kind of work or you're in mental health work. And so make sure clients understand that you would never expect them to know these things because there's been no part of their lives where they needed to know them. So that's it on psychoeducation. I'm happy to talk more about it, but it's such an important part that as we talk about different protocols of treating trauma, you'll see that it's built into almost all of them. The second thing we're going to cover in this mini lecture are cognitive interventions. And as you're doing your reading, please remember that cognitive interventions, while they're called cognitive interventions, and so we're talking about a person's thoughts and what's happening in their brain, we're building all of this on relationship, on acknowledging the biology that's involved in trauma. And we know that a client may need multiple types of interventions to help them work through their trauma. So after a person experiences a trauma, it is very natural for the person to engage in repeated thinking about the event. And that could be called rumination or reflection. There are two different types of that. So deliberate, so meaning the person is bringing those things to mind and thinking about them purposefully in a self-reflective way. Or intrusive rumination, which occurs when it happens without the client meaning for it to. This could be involved, like a trigger may cause this. It could be a nightmare, or other times where the client does not have control over their rumination. And what can happen in the repeated thinking about the event is a cognitive accommodation, meaning we think about it and so we're able to sort through it. But that only happens if you have deliberate rumination. It does not happen if you have intrusive rumination. So one of the goals of cognitive work after trauma is to focus on that deliberate rumination and intellectual self-reflection to help the brain accommodate and assimilate the information. And it turns out that's kind of a big deal. If you are able to do more deliberate rumination and have lessen your symptoms of intrusive rumination, then you will likely be able to lower your symptoms both in severity and then also in repetitiveness. And so, if someone is not able to reduce the intrusive rumination symptomology, their psychological distress will continue to escalate, which of course makes sense. If you have things intruding in your thoughts, in your sleep, distressful, traumatic memories, of course your psychological distress is going to stay on high alert and you're going to be, hyper alert, hyperactive, always ready for the next shoe to drop. So it's important in our cognitive work with clients that we help them assimilate that information through a structure. And for most cognitive trauma work, we call that the trauma narrative. And so you'll hear me say that a couple of times as we talk through this. So cognitive integration happens within two steps. The first step is trying to take all of the information from a trauma event, and remember that information is going to be fragmented because our memories and our brains don't work correctly when we experience a trauma. So you are trying to take all of the information from the trauma and turn it into a cohesive narrative, for lack of a better word, a cohesive event, so that your brain can say, okay, I know what this is, and I have all these different pieces that are not put together yet, but you have all the puzzle pieces and you can see them in front of you. And as you work on these different aspects of the trauma event, the client will start having more control over their symptoms because they are identifying their triggers, they are remembering different parts of the trauma. And so all the puzzle pieces are on the desk in front of you, they're just not put together yet. As you work through, taking these, the trauma schemas and the intrusive ruminations, and you turn them into purposeful reflection, they're putting all of this together. Okay, well, I realized yesterday that the smell of citrus is a trigger for me because I could smell that when, that was my air freshener in my car when I got hit by the other car. And so now I have that puzzle piece. And so I can put that as part of my purposeful reflection. So what you're doing is taking all of these things that have been intruding and having the client talk more about them, dig into them, explore them, so that they are not just intrusive, but purposeful reflection. And then the second step of that is moving from reflection about the meaning of the event or what all of the things it caused to go wrong, all of the troubles that it's put forth in their life, into integrating what it means in their own life. And so how have they responded to it? How may they start responding differently? How are they going to use it as a bookmark in their life or a jumping off point or something else? And that will look different for different people. I mean, for some folks, meaning making is just acceptance. This happened and it sucked, and I'm doing what I need to get better, and that's enough. And other folks may find even deeper meaning making in the result of healing from their trauma. And we may see them go on to do different things with their life, like become a counselor themselves, or they may choose to do more volunteer work or other things that kind of carry forward the meaning that they've created from the trauma. So this is important. This is a good way to, kind of outline how we work on cognitive symptoms. And some research has showed that when we're not doing that purposeful reflection, all of the suppression and avoidance that a client is doing with those thoughts just makes them worse and makes their symptoms worse. So it may hurt to start processing these things, whether you do cognitive alone or cognitive work plus somatic work. It's still painful because you're putting yourself in a vulnerable situation. However, if you don't do that, the likelihood is that your symptoms are going to get worse over time. So that's important to tell clients as well. All right. So cognitive interventions explore negative perceptions and beliefs about yourself and others, your worldview, as a result of the trauma that has happened. As I mentioned before, trauma narratives are often used to explore the story of the client through all of those senses and memories, both intrusive ones, things they can purposefully recall, and put this together into a cohesive narrative. And trauma narratives can be explored both verbally in session or through writing. That will just depend on the client's preference, and should include not just the story of what happened during the trauma, but also feelings and thoughts that went with it. And so working on a trauma narrative can take many sessions. It's not something that necessarily you would expect a client to do in one session. It can be done through partially, at least through homework, if the client is in a safe and secure enough space and state of mind to do that. But I tend to prefer doing this work in session. And as you're working through the trauma narrative, you often will have multiple drafts. So just like you're writing a paper, you're going to have multiple drafts. So the first draft may be mostly details and facts. Well, tell me what you remember about the car accident. Well, the police officer said this, and this happened. So your first draft are your details and your facts that maybe they know, or they know because somebody told them. And then as you work through that multiple times, your job as a counselor is to ask questions and make reflections and, seek that meaning to help them pull in the feelings and thoughts. And your secondary job is, once you have a more full picture of the trauma narrative, pointing out those negative perceptions and beliefs and help replacing them. Well, this wouldn't have happened if I had left 5 minutes early, instead of leaving and running behind and speeding. I wouldn't have been in a car accident if I wasn't always behind, I'm always late, I'm a terrible person that this happened. So whatever those beliefs are around the person's trauma that are not helping them move forward, it's going to be your job to hear those, listen for them, identify them, and then help the client replace them. And over time, a more coherent trauma narrative will emerge that will hopefully help move the client towards healing. So some of the things that this is your job during the trauma narrative. Listen for repetitive patterns and thoughts and beliefs, particularly guilt, shame, blame, things like that. Ask the client what cognitive distortions they hear. Don't use the word cognitive distortions, but do you hear any statements in your trauma narrative that you know within yourself are untrue? Or maybe beliefs about that are coming from somewhere outside of your lived experience. So whatever the developmental ability is of the client, you can kind of change your language to match. Ask the client to refute the distortions. Now, once again, just like when you're reflecting meaning, what the client tells you, what they come up with will be more powerful than you just handing it to the client. And so ask the client to come up with a combative statement to fight against those feelings and thoughts of blame, shame, guilt, and then reflect those back to the client. If they really can't come up with any ways to refute the distortions, or they can't come up with the distortions themselves, then use a brainstorming activity to do that together, but don't do it for them, together or just the client. Once the client knows about their patterns, it's probably going to tell them something about not just the trauma, but their perceptions of themselves and their own personality and how they view themselves in life. You will work with the client to help them reconstruct a more accurate and also healthy portrayal of the trauma. So, there's no way for me to know if I had left 5 minutes earlier that I would not have been, hit by a car. Okay, well, I say I'm always rushing, I'm always running behind. However, the other car ran the red light, and so I don't have any control of what other people do. And if it wasn't me, it probably would have been somebody else. So that's not my fault. That's not my burden to carry. That's somebody else's. And so just sort of kind of combating those and coming up with an accurate portrayal of the trauma that allows the client to see themselves with more grace and more compassion. This can be, difficult when the client is still very activated. And so that's why using grounding techniques and making sure that the client is very ready for this work is super important. Cognitive distortions are loudest when we're actively recalling the trauma. So the voices in our head that tell us that we're bad, that we should be ashamed, that this is all our fault, they're loudest when we're talking through the trauma. And so you do want to make sure the client is stable before you do this, and then also know that you can always go back to those grounding skills if it feels like you're getting, if the client's getting a little too activated. So we'll talk a little bit about meaning making. Everyone does this a bit differently, and there's no formula for the right way to create meaning out of a trauma. And some people never create meaning, and that's also okay and a legitimate reaction. That it's very normal to default to self-blame. Not just self-blame, but catastrophizing and fear that everything bad that could happen is always going to happen to you. So very, very normal reactions to trauma, especially when you are still dealing with the stuckness that happens in the brain after a trauma. As you work through these, through cognitive interventions and or somatic interventions, oftentimes that clear narrative contradicts the thoughts and feelings that lead to the self-blame and catastrophizing. So you're actively working to reduce that while you are also increasing the client's understanding of a narrative that's free from the values and judgments that they are putting on themselves. And it's also really helpful, to just say to clients repeatedly, You know, if something is all or nothing, it's likely not true. Like that's not a true statement for almost any life situation. I think if we have, you know, a spectrum and on one end it's all and on the other end it's nothing, most things in life are somewhere in between those two on the spectrum. And so all or nothing thinking, I think is another form of pathology that we work with clients to refute and to replace with more positive understandings. So through reassessing the past and looking into the future, applying what the client has learned to both narratives from the past and the future, oftentimes clients are able to create meaning. Even if it's through, you know, something like, well, I understand myself better and I'm creating meaning in the process of understanding myself better so that in the future, when something bad happens, I don't default to everything is always my fault. All right. So this is a case study that I would like for you to pause and read, and then read the discussion questions. Once you are finished, I'd like for you to maybe take some notes about how you answered these questions to see how you would approach this specific case. Okay, so hopefully you've had some time to pause me and read the case study and answer the questions, and I'm just going to walk through this some with you. So what negative beliefs and thought patterns exist? You can see here that she is blaming herself for being too friendly. She is saying that she should have said no, which of course is what we teach people, you know, always say no, but our brains don't always listen to that advice. And so we're often incapable of doing that. She thinks that she should have known better than to walk alone at night. So those are all negative beliefs and thought patterns that are present in her narrative. The alternatives that I would want her to identify would a lot of times I think come from psychoeducation. So I would talk about, you know, the biology of fight, flight, freeze. I would talk to her about our cultural expectations to be people pleasers, particularly as women. I would talk to her about how she wasn't walking home alone at night. She was with someone that she thought she could trust. And there is nothing wrong with believing that you can trust someone if they have shown themselves to be trustworthy in the past. So those are some of the things that I would want to use psychoeducation to talk to Mira about. Some alternatives that I would want her to identify are different ways to talk to herself about the blame and shame. One example would be, I could have said no if my brain had allowed me to, but it didn't. You know, and so that kind of allows her to let go of that blame because her body was in a fear response, and we don't have a lot of control over what our brain tells us to do during those times. What insights do I want her to find? You know, I want her to find like grace for herself. I want her to hold herself to a standard that acknowledges that she is not responsible for other people's behavior or choices. And you know, I think that through some of this work, especially around her symptoms on wanting to stay home, which is avoidance, feeling suspicious of both people she knows and does not know, that's inability to contextualize, which means that she's now stuck in a state of extreme paranoia. Again, contextualization is vital for us to know when we are being paranoid and when we aren't. And so I talk her through these symptoms. I talk about how they're normal, how they are responses to trauma that we can work through, and that I would probably start after psychoeducation with the avoidance through whatever protocol I decided was a good fit for her. And then you would want to reinforce her new narrative through, you know, the whatever thoughts she comes up with. So I am not to blame for my sexual assault. I am not to blame for not saying no, and I am not to blame for other people's choices to violate me. And I would reflect those back to her as reminders as often as she needed it. So I hope that was a helpful illustration. We're going to talk about a few cognitive evidence-based treatments. I do want to say that most of these require extra training. Some of them, however, it's as a little as purchasing a manual and familiarizing yourself with the treatment. Others may be a little more advanced where you need to do workshops to learn how to use the techniques. But if you choose to work in trauma, having a repertoire of evidence-based treatments for trauma is super helpful. And so I do highly recommend getting or seeking training if this is the kind of work that you want to do. So the first thing I'm going to talk about is trauma-focused CBT or TFCBT. I actually received this training through my first job. I was working as a school-based mental health counselor after Hurricane Katrina. And as you can imagine, there was a lot of trauma in the schools for multiple reasons. And our agency brought in someone to train us in TFCBT. That is one benefit of sometimes working for agencies versus private practice, is they may be more willing to invest in your training versus you having to pay for it all yourself. So TFCBT was originally developed to treat children and adolescents. However, it's also used with adults today. It is a protocol, and so you would use the workbook to kind of go session by session. And then the main topics I have here in the overview outline those main sections. Now, that doesn't mean that you would just have one session for each of these. You could spread this out over multiple sessions. You can also do this in a group format, which in the schools was really helpful. But essentially, you are working through each of these topics as part of the TFCBT protocol. The first is psychoeducation, and if you're working with teens, parenting strategies for their parents. Relaxation, where they would learn different strategies, like progressive muscle relaxation, mindfulness, things like that. Then you move into affect expression and regulation. From emotions, we move to thoughts, so cognitive coping. After you've done all that preliminary work, you're going to move into the trauma narrative, which could, as we talked about before, take multiple sessions to work and edit through multiple trauma narratives. You would then, in situations where it is fitting, you could do in vivo exposure, but that's not always going to be necessary. Again, you know, if you are working with child, you could move into parent-child sessions. And then lastly, what you'll work on is enhancing personal safety and growth. And so I did put you a link in here to the training. If you are interested in learning more about TFCBT, it is really good for those who want to work mostly with kids or see themselves working in group work. I think that it's a helpful protocol. Next, we have cognitive processing therapy, and I think that CBT is one of the more researched methods of working with trauma because it has been used in the VA with the treating veterans. And we know that when government is involved, you're more likely to get government funded research. And so this specific technique and therapy has been researched a good bit. And it's based in cognitive behavioral theory with an emphasis on working to help the client get unstuck. So you know that trauma gets you stuck. And so the goal of this is to get you unstuck. It's a 12-week structured process. So just like TFCBT, you have a manual that you would follow, and you have a certain topics that you would cover until you felt satisfied with those topics and then moved on to the others. It does start with psychoeducation, like, you know, most trauma protocols. Psychoeducation helps prepare a client to start then working on their trauma. It increases the awareness of thoughts and feelings, and then it helps the client to learn specific skills in order to challenge those distorted thoughts and beliefs and then cope more effectively. And because of that, the client's understanding can change around their beliefs and their worldview about safety, trust, relationships, being able to contextualize events and people again. So I did put a link here as well if you'd like to learn more about CPT. That is a specific training which you can access as well. And I put this in the Canvas page, but I'll say it here as well. I really, really recommend that you finish at least this course before seeking advanced training, potentially your entire graduate program. Advanced trainings are very specific, and so they're going to give you some really good tools for working with very specific issues, but you need to start with a strong generalist foundation, which is, of course, what graduate school gives you. And then lastly, I wanted to talk a little bit about narrative exposure therapy. So I went back and forth between putting this in the cognitive section or the advanced treatment section for next week. And the reason I struggle with this is because narrative exposure therapy is an alternative to exposure therapy, which is not a cognitive-based intervention. So narrative exposure therapy includes working through a trauma narrative, but on a bigger scale. So you would do a chronological narrative of all your life events. And it works to add context to traumatic memories so that you can form a more cohesive narrative. The reason I think this is an important therapy for us to think about and talk about is that exposure therapy is highly effective and can also be highly re-traumatizing. So in a lot of studies, 40 to 50% of the participants of exposure therapy drop out because it's just too distressing. And so if you manage to hang around, it's probably going to be pretty effective for you, but a 40 to 50% dropout rate is also pretty extreme. So I think narrative exposure therapy, or NET, is a good option for this. And it has a good bit of research behind it that shows that it can reduce trauma symptoms, increase hope, and increase your quality of life. And it has a child protocol as well called KidNet. So I put an excerpt here from Deborah Kuzman of the Hanley Center that talks about what to expect in a narrative exposure therapy session. I'm not going to read that, but feel free to pause the recording so that you can read it and learn more about it. So this is one of the therapies that you could buy the manual for and learn how to use mostly on your own. I would still encourage you to do some learning around webinars or workshops or conference sessions to learn more about this if this is something that you want to pursue. However, you can buy the manual for about $40 and learn more about how to use this option. All right, that's all for this week. That's all. I know it was a lot, but we are at the end of the content for this week. And so thank you for hanging around. If you have any questions, feel free to email me or post it on our classroom discussion board. And I hope you all have a wonderful day.